This slide's particularly cool, and it's particularly important. What I want you to realize, now, let's think about the tracts we already know. We know about the corticospinal tract, and this is the tract that results in voluntary movement. We monitor these with motor evoked potentials, correct? Well, we know that there's an upper motor neuron there, and that upper motor neuron is on the precentral gyrus, or primary motor cortex, and that it descends in the corticospinal tract. I'm just jogging your memory. I'm not showing you anything, right? I'm just talking you through this. Descends in the corticospinal tract, goes down in the medulla, and it crosses, decussates, right, in the pyramidal decussation, goes down to the level that it's going to innervate the lower motor neuron, which is the alpha motor neuron. Remember, that's in the ventral horn, the spinal cord. Right? You need to know these things. If you don't know this, we need to look this up or call me for some help. And then that alpha motor neuron exits the spinal cord through the ventral root and goes and innervates the limbs. All right? So it's a cross pathway. We know that if we have a stroke on the right side that involves the motor cortex or precentral gyrus, we know that we're going to get a deficit in the left side motor. Okay? We also know that upper extremity is out lateral, remember the homunculus, and that the vascular supply is the middle cerebral artery. We know that the lower extremity is found more medial, so I illustrated on here, lateral medial, and the vascular supply is anterior cerebral artery. All right, now let's talk about the facial nerve. It's a different pathway. It's called the corticobulbar pathway, bulbar meaning brainstem. So all of the motor cranial nerves have their upper motor neurons, again, in the primary motor cortex, precentral gyrus. Now, they tend to be out laterally, right? Because face and upper extremity is lateral on the homunculus. And their blood supply is going to be the middle cerebral artery. So the upper motor neuron that contributes to the facial nerve later on, or innervates the lower motor neuron that contributes to the facial nerve later on, is up here, primary motor cortex, out laterally, middle cerebral artery. Now, it comes down through the internal capsule, and it crosses. Some of the fibers cross, and some of the fibers do not cross. All right? Some cross and some don't cross. Generally, the face is controlled by the contralateral brain, with the exception of mainly the forehead, okay, the temporal branch of the nerve. The temporal branch of the nerve has bilateral input. So some of the fibers that crossed from the other side contribute to it, but some of the fibers that stayed ipsilateral contribute to it, okay? Now, where am I going with this? Well, there are two types of lesions you can have. You can have a stroke in the face area of the motor cortex, or you can have a lesion in the facial nerve itself, or in the facial motor nucleus. How do you know what's what? Well, if you look at your patient and their injury or their deficit is in the lower quadrant of the face, then you know they had a stroke on the contralateral side of the brain. So if you're looking at their right side of their face, as you are down here, you know that they had a left-sided stroke, okay? You know it wasn't a nerve injury because they're still able to move their forehead. If you look at the patient and have a complete hemiparalysis or hemiparesis, you know that you have a lesion in the facial nerve or in the facial motor nucleus, right? Because they can't move their forehead, which means that all of those fibers were damaged, as opposed to, in this case, just the contralateral fibers. Okay? Here's an example of a facial nerve lesion. Notice this gentleman's trying to smile, and on the left he's able to do so, but on the right he's paralyzed. This is the end of part 1. We'll resume this course in part 2.